Dear Professor Shabala, dear colleagues, thank you very much for giving me the chance to present a clinical update in osteogenesis imperfecta. It was a very nice introduction you gave at the beginning, and I really enjoy the possibility to present this and thank Emgen for this possibility. I have no conflicts of interest related to this special talk, and I want to give you at the beginning a brief overview about the symptoms and the pathology of the disease, and then focus on the currently available therapeutic options. Has an incidence of 1 to 20,000 births, and this means that we have around 14,000 affected individuals in Europe. Osteogenesis imperfecta is a collagen disorder causing a reduced amount of bone with an increased fracture rate. It is mostly inherited in a dominant way and has a huge range of different phenotypes. All phenotypes focus on the involvement of the musculoskeletal system, and the patients have no cognitive involvement. The most dominant symptoms are the skeletal problems, which are fractures due to inadequate traumata, deformities of the long bones, and fractures of the vertebrae and scoliosis, which develop in most patients during pubertal age. These are the main skeletal symptoms, but you have also some non-skeletal symptoms, which include a hypermobility of the joints, the short stature of the patients, and round about 50% of the patients have a discoloration of the sclera with a gray or blue sclera of the patient. The disease was classified depending on the severity of the clinical symptoms into 4 types. The type 2 is the most severe type. These patients normally die during the first days of life due to pulmonary problems. And then you have the 3 remaining types. Type 1 is the mildest form of osteogenesis imperfecta, which normally has no relevant symptoms during adulthood and only some fractures during the childhood. Type 3 is the most severe type, where most patients are depending on a wheelchair, and all patients who will not fit into a type 1 or a type 3 are normally classified as a type 4, a moderate type with many fractures during childhood, but nearly without fractures after the end of growth, after puberty. Then, if you think about how these fractures occur, why there are so different phenotypes of the patients, there are 2 main pathways in the bone formation which can be affected in osteogenesis imperfecta. If you have a mutation in the collagen genes which cause a stop mutation, you have a normal collagen normal structure of the collagen molecules, but you have a reduced amount of collagen. This is especially problematic during childhood when the bone grows. Then you have an impaired stability of the skeleton system and the fracture occur, but after puberty this normalizes. In the more severely affected patients, when you have a qualitative defect of the collagen, where the collagen molecules cannot form correctly, then you have an impaired quality of the collagen in addition, and these are the severe type 3 and 4, which also suffer from skeletal problems after puberty. When you look at the bone in specific on a tissue level, then in all of the OI patients, you of course see that the amount of bone they have is reduced, the bone mass is reduced, but the bone which is present has no mineralization defects. In contrast, the bone which is there shows a hypermineralization. This is different to adult osteoporosis, and this means that a treatment with calcium or vitamin D does not make a lot of sense because the bone is already hypermineralized, but there is not enough osteoid or bone which can be mineralized. So here the therapeutic ways or possibilities differ between OI and normal adult osteoporosis. When we look at the disease on the genetic level, then you see that most of the patients, around 80%, are caused by dominant mutations in the genes Col1A1 or Col1A2, but during the last years, a lot of recessive types have also been described, causing more severe cases of OI, and the need to focus on these rare types is that they provide some more insight during the pathophysiology, and then you can think about new therapeutic approaches, as I will present you in a few minutes. So regarding the therapeutic options, the treatment is based on three main areas: a medical treatment, the surgical or orthopedic treatment, and the physiotherapy or rehabilitation treatment. To start with the last one, muscle strengthening to cause an osteoanabolic effect is important for children and adults with OI, regardless of the underlying genotype or phenotype. There are a huge variability of training possibilities: swimming, treadmill training, vibration training. Everything what activates the muscles is good, and because there are so many different therapies used, there was a first attempt to harmonize the treatment a bit by publishing a consensus paper for the use of physiotherapy and rehabilitation in pediatric patients with OI. Besides the muscle strengthening, of course, if you have a fracture, you need the surgeons and the orthopedic doctor. If you have a fracture which is not severely dislocated, you can use a conservative treatment with a cast and immobilize the bone. But if you have a patient with severe deformities of the bones, then of course you need to do some surgery to give the patient the possibility for weight bearing, for standing. So you need to do the surgery in the growing child, put in a telescopic rod which will stay in the bone, avoid dislocated fractures during the whole childhood, and then you have a more or less straight bone which can be trained for mobility, for standing, for weight bearing. So these are the most important non-medical treatment options you have for these patients. And regarding the medical treatment, there is a difference between patients with adults and for children which still grow. The first medical attempts have been the use of bisphosphonates, which have been used here in a pediatric setting. IV bisphosphonates increase bone mineral density in the lumbar spine, and here you see the individual increase during the treatment periods, and the bone density increase, the bone pain decrease, and the patients become more mobile, more active in these treated patients. So, of course, in adults, you don't only have bisphosphonates available, you have other drugs available also, but if you look at the bisphosphonates, you have very different bisphosphonates available, and you see a positive effect not only in the first shown hamidronate, but also in niridronate, where you see an increase of bone mineral density compared to a placebo-controlled trial when using niridronate, but this is the same for other bisphosphonates as well. So bisphosphonate use in adults is the standard of care, but there's also some trials using osteoanabolic agents like teriparatide for a shorter period of 1 to 2 years, showing an increase of bone mineral density and improvement of the biomarkers compared to a placebo-controlled trial. And this might be sometimes a good possibility after a fracture if you have immobilized patient where the muscles cannot give an osteoanabolic effect, so then you can have the anabolic effect by a treatment with teriparatide. A new possibility for the future might be the use of anti-sclerostin in adults, and a first trial has shown some good response of the biomarkers when treating adults with or with anti-sclerostin, but this is only the first preliminary results which have to be further investigated and assessed. So when we now look at the pediatric setting, we have a few more data available because the symptoms are most prominent in the pediatric setting. So a lot of investigations have been done in this age group. As mentioned before, pamidronate was the first used bisphosphonate in children, and you see here that with this treatment you can not only improve bone mineral density or other biomarkers, but you can also really improve the situation of the patients, improving the percentage of patients who are able to walk. The proportion in the treated compared to the untreated group is much higher, so you really have a positive effect in the mobility of the patients. At the beginning, I mentioned the genetic heterogeneity of the disease, and this is important because the elucidation of the genetic cause of one of the rare types provided a new insight into the pathophysiology. In some patients, patients with an OI type 6 have a mutation in a gene as the underlying cause, which influence the activity of osteoclasts directly. So not the collagen is affected, but the osteoclasts are more active, resorb more bone. The consequence, reduced bone mass and increased fracture rate, is the same, but the pathophysiology is different, and it was known that in these patients the treatment with bisphosphonates was not very effective, and therefore we started to treat these patients with denosumab as a direct osteoclast antibody, and we saw that these patients responded much better than before to the medical treatment and showed an increase of bone mineral density. After we have seen that this treatment works so well, we decided, well, let's see if this might be a possibility also for patients with a classical OI due to collagen mutations, because the application of denosumab compared to IV treatment was also something which would be beneficial in a pediatric setting, and we did a small trial and saw that the increase of bone mineral density was higher during the treatment phase with denosumab compared to the previous treatment with bisphosphonates. Of course, this was just a small trial, not double-blinded, no placebo-controlled comparative arm, but this is the first hint that denosumab might be beneficial in these patients, and this needs to be investigated further in bigger trials. Nonetheless, during the last few years, we pediatricians learned from the adult field and learned that the rebound after you end the treatment with denosumab might be problematic, and you have this rebound and the hypercalcemia in these patients, and that's a relevant problem in the pediatric field due to the need to stop the treatment at a time. You don't want to treat the patient for their whole life. You start in a newborn, and therefore this needs further investigation, how to end a treatment, how to avoid hypercalcemia after the cessation of a treatment with denosumab. Nonetheless, this is a new therapeutic option which needs to be investigated and which might be a suitable treatment in the future. So to conclude this presentation. Osteogenesis imperfecta is a genetic disease. Most of the patients are affected by mutations in the collagen genes or in genes influencing collagen processing in and outside of the cell. The phenotypes and genotypes show a very wide range. We will not be able to solve the disease only by using medical treatment. You need an interdisciplinary approach with physiotherapy, surgeons, medical treatment. At the moment, bisphosphonates are the only approved and available and very well investigated treatment for children. Every other therapeutic approach is an off-label use and cannot be recommended outside of clinical trials. And first small trials showed a good effectiveness of denosumab in children, and we hope that in the future we also will have more information about the pediatric field and then also about the adults and how long to continue such a treatment and how to end it. With this, I want to thank you for your interest and time and look forward to the questions in the end of the session.